Good afternoon, everyone. This is Janice Whitaker, the CGNE Administrator and Community Liaison, and it's my pleasure to serve as host of the CGNE Seminar Series. I'd also like to introduce Jenny Rank, our CGNE Education Program Specialist, who will be helping to facilitate the Q&A discussion portion of the session. Today's seminar on delirium screening and management from two perspectives will be co-presented by Dr. Andrea Sillner and Leandra Davis. Before the seminar begins, as always, I have some announcements and disclosures to share. First of all, the seminar is being recorded. If you're on Zoom, please remain on mute. And if you'd like to come off of mute, there is a raise the hand feature at the bottom, and Jenny will monitor for that. If you keep it in the gallery or thumbnail format, you'll see both our speakers and the PowerPoint slides. If you have any comments, please enter them into the chat. And if you have questions for the co-presenters, please put them in the Q&A feature. And again, Jenny will be monitoring that for us. The post-event evaluation and survey link will be placed into the chat at the end of the seminar. It will also be emailed to you within 24 hours. The evaluation must be completed within 1 week of the seminar. And while this is required for registered nurses seeking contact hours, we do ask that all attendees complete the post-event evaluation to assist with data collection related to our center activities, as well as for the Age-Friendly Care PA initiative. Contact hour certificates will be emailed to registered nurses, meeting all the requirements within 1 month following the seminar. Penn State Ross and Carroll Nese College of Nursing is an approved provider of nursing continuum professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. At this time, presenters, organizers, and content specialists have indicated no conflict of interest. This activity has been submitted for 1 contact hour for participants who hold a valid RN license, attend the entire session, and complete the evaluation. Partial contact hours are not awarded. This program is being provided by the Penn State College of Nursing, Teresa Nese and Helen Diskovich Center of Geriatric Nursing Excellence in collaboration with the Center for Nursing Research and Age-Friendly Care PA. If you have any questions or comments, please feel free to reach out by email to cgne@psu.edu. And next, I would like to thank Logan Sweeter, one of our CGNE affiliated PhD students, for introducing our co-presenters today.
Thank you. Andrea Sillner, PhD, GCNS BC RN, is an assistant professor in the Ross and Carroll Nese College of Nursing at Penn State University. She is a geriatric nurse scientist and has a funded interdisciplinary program of research focusing on improving person-centered communication between older adults, their informal family caregivers, and their formal healthcare providers across settings of care. Currently, Dr. Sillner is the principal investigator of the Preferences for Technology-Assisted Communication, or PTAC project. The goal of the project is to develop and test a tool to assess older adult preferences for using technology to communicate with their formal healthcare providers. Influences of communication and barriers and facilitators to using technology to communicate have also been explored as part of this work. Her long-term goals are to develop interventions aimed at empowering older adults, particularly those with dementia, and their informal caregivers to have critical conversations with their formal healthcare providers in the community. Dr. Sillner was a 2009-2011 scholar in the John A. Hartford Foundation's Building Academic Geriatric Nursing Capacity Program. Prior to becoming an assistant professor at the Penn State University College of Nursing in 2020, she spent 5 years as an assistant research professor, also at Penn State, and was an assistant professor at Duquesne University School of Nursing. In addition, she practiced as a medical surgical orthopedic nurse and a wellness nurse coordinating and managing care for independent living residents within a continuing care retirement community. We also have Leandra Davis, BSN, RN, BC, an assistant nurse manager on 6 acute care medicine and niche coordinator at the Penn State Health Milton S. Hershey Medical Center. Leandra began her career as a graduate nurse on 6 acute care medicine and will celebrate her 12-year anniversary working for Penn State Health Milton S. Hershey Medical Center in November 2021. In that time, she has served as nurse preceptor, charge nurse, clinical head nurse, patient safety champion, and now serves as an assistant nurse manager. In this position, she has been recognized with Nurses Week Award for excellence in adult acute care nursing and excellence in nursing education. Additionally, Leandra served as niche coordinator for Penn State Health Milton S. Hershey Medical Center. In this role, she leads initiatives to improve the care of older adults by implementing evidence-based geriatric care models into clinical practice. Leandra was instrumental in bringing and implementing the Hospital Elder Life Program, a proactive ambulation program for 6 acute care medicine focusing on preventing the functional and cognitive decline of patients aged 65 and older. Serving as a co-lead as the IHI Niche Steering Committee, she collaborates with the interdisciplinary team that oversees the implementation of the 4Ms framework. Furthermore, Leandra supports nurses in attaining their geriatric certification. Leandra graduated from Colgate University with a BA in molecular biology and attained her BSN from Drexel University.
Thank you, Logan. I'm just going to begin our presentation today, and we are super excited to be here. I know we're both very excited about the topic at hand, which is delirium screening and management from 2 different perspectives. So throughout our presentation, you're going to hear a bit from me and a bit from Leandra about this topic. So objectives for today, we're going to talk a little bit about delirium, and also screening tools for delirium, but primarily focus on implementation of those tools in an acute care setting and sort of what has been helpful in an acute care setting and what has limited implementation of those. So to begin, whether you are a practicing nurse for 15 years or whether you are a student or a nurse scientist, I think you can agree that the majority of the patients that we see in an acute care setting are older adults. Older adults are frequently hospitalized, and as we continue to age, this is going to become increasingly significant. Older adults are hospitalized for many reasons, and unfortunately, as a group, while in the hospital, they often experience negative consequences. One of those negative consequences is delirium. Delirium is defined or described as a disturbance of attention, awareness, and a change in baseline cognition. Older adults with delirium have a significant change in a period of hours or days. They may have symptoms such as being easily distracted, inability to focus on a topic or conversation, withdrawing from others. They may have poor thinking ability, impaired memory. They may also have sleep disturbances or being more tired than normal, calling out, having irritability, among many other symptoms. Delirium typically includes 3 different types: hyperactive, hypoactive, and mixed delirium. Delirium itself is multifactorial and can occur as a result of metabolic imbalances, infection, surgery, and many other factors. Those with pre-existing dementia are most particularly vulnerable to delirium. So what places hospitalized older adults at risk for delirium? First is just being an older adult, and secondly is just being in the hospital. There are many other factors such as medications, Parkinson's disease, stroke, having a prior episode of delirium, sensory impairments, or having multiple chronic conditions. Unfortunately, in addition to having negative consequences in general, hospitalized older adults with delirium experience significant negative issues. These may include, but are not limited to, longer lengths of stay, increased healthcare costs, and increased risk of morbidity and mortality. And so what I've provided you is just a brief overview of some of the factors that contribute to negative consequences of delirium in the hospital. But I want to hear from Leandra about her own experience. So as a Penn State Health Milton S. Hershey Medical Center nurse who's been there almost 12 years, what do you see in terms of your own unit with older adults and delirium?
So yes, I mean, we definitely see patients that not only come in with, a diagnosis of dementia, which you said earlier places them at higher risk for delirium, but also really inhibits their, maybe sometimes their diagnosis, or really hinders our plan of care for them. So what we decided to do, and where our journey really began, as far as focusing on delirium and how to improve the care for our older adult patients, we decided to, as an organization, look at NEACH. So NEACH stands for Nurses Improving Care for Health System Elders. And this journey really began back in 2018, where I was asked to serve as a NEACH coordinator for the Milton S. Hershey Medical Center. And what that really means is that our site is dedicated to improving the care for our older adult patients. It really focuses our strategic plan for one of our main objectives to not only become a NEACH member, which we did in 2019, but then to actively pursue further senior recognition from NEACH, which includes a senior friendly recognition and also an exemplar recognition. And this really just helps to, again, impart those essential principles and tools to help improve the care for our older adult patients. And one of the most important things that some of you might know regarding any great initiative is making sure that you have some of those key stakeholders within your organization that is going to support anything. So I am so grateful that at the Milton S. Hershey Medical Center that I was actually approached by members of an executive and nursing leadership in order to implement this change that we were going to see not only in our organization, but as I go through and describe some of the interventions that we have in place, and at the very end, our next steps, really throughout our healthcare system. So today I just kind of wanted to take a chance to just to recognize those stakeholders, mostly at an executive level. So Deborah, our president, is very involved with this. Also, Dr. Ariana, our chief medical officer, and now more recently, Michelle Skolnicki, who is our chief nursing officer. Nursing leadership that have been instrumental in just their support, not only to me, but also the initiatives that we have for our older adult patients. First of all, Vicki Shiflett, our nurse manager in 6 Acute Care Medicine, that has been very supportive of this and of me. And more recently, our interim vice president for adult acute care, Jenny Zimmerman. And then lastly, I just wanted to recognize too that with this great initiative, even though NEACH is a very nurse-driven and nurse-focused initiative, we also needed interdisciplinary support in order to make this happen. So we have partnered with multiple disciplines, and some that I want to mention today are Dr. Nicole Osavala, who's a staff physician for geriatric medicine, Dr. Brian McGillen, who's a staff physician and also a hospitalist, Jill Reebok, who is the director for clinical pharmacy services, Lori Benner, who is a manager of our therapy services, Monica Cascarino, who's the VP of our care management, and more recently too, just involving our operational excellence team to make sure that we stay on track and really help to implement more broadly some of the stuff that I'm going to be talking about. So these stakeholders really really mean that they really want to make sure that our making our health system age friendly is a priority. So I just wanted to share with you our mission statement that we actually created back in 2019, which is enhancing organizational commitment to improving the quality of care for hospitalized older adults through evidence-based geriatric standards and geriatric education for hospital staff members. So again, as I said, our first journey to becoming age friendly really started at the nurse level, really looking towards niche, which again is a nurse driven, unit focused type of plan. But as we started our journey and through the help of other resources, including Andrea, she was very much instrumental in letting me see that this really aligned with the age friendly recognition related to the Institute for Healthcare Improvement. So our objectives with niche really started to align with their objectives and their goals. Niche serving as the backbone for IHI and really focusing and seeing how they worked synergistically. So the IHI for age-friendly health systems really focuses on a 4Ms framework, which currently a lot of our work in the past couple months have been focused on. The 4Ms framework stands for mobility, mentation, medications, and what matters. And today we're going to be focusing on that mentation portion, which really means from an IHI standpoint is to prevent, identify, treat, and manage dementia, depression, and delirium across the care settings. What we really want to see is that every older adult patient should receive this set of essential care principles at every point of contact within our health system. Really just making the care of our older adult patients, which can be quite complex, more manageable, and really just looking to improve their patient outcomes.
And so as part of improving patient outcomes, the evidence tells us that there are certain best approaches to implement in clinical practice with regards to screening and management of delirium. This, of course, could be a whole topic and conversation in and of itself, but I'm going to briefly cover a few different areas. So screening, specifically nurse-driven screening, and also management. So how can nurses help? Screening upon hospital admission and throughout the stay is critical to identify delirium and also to manage delirium. It's important not only that we do this at admission, but also throughout the hospital stay, as factors or risk factors for delirium may evolve or change with the treatment plan. For example, somebody may become dehydrated throughout their hospital stay, have an increasing number of medications, or have another invasive device such as an indwelling urinary catheter placed. There are many nurse-driven screening tools. I'm going to cover a few of the more popular screening tools or protocols. And first, we're going to start with the UB2. So the UB2 is an ultra brief 2-item screen. It's quick. It's easier to administer. It takes about 1 minute. It has been tested with physicians, nurses, and nursing assistants using it as well. It includes a 2-item assessment of orientation and attention, meant for delirium case identification. So these are not diagnostic screening tools. All of these screening tools would allow for further diagnosis and management if the individual screens positive on these. If either of these UB2 items are answered incorrectly, then the patient should be referred for that more diagnostic interview. Another tool is the ultra brief screen for detecting delirium. And this was specifically derived in a group of post-operative cognitively intact older adults. So those age 70 and older undergoing major surgery who had high cognitive and physical functioning at baseline. It is another quick and easy screen. It can be administered by any healthcare staff. So again, that same group of physicians, nurses, and perhaps even nursing assistants. It identifies those who may need additional testing as well. Having one or more positive or incorrect responses is equivalent to a positive screen and indicates further evaluation is needed. So these are questions asking the patient if they have felt confused in the past 24 hours, asking them to tell me the months of the year backwards, and asking the assessor if the patient appears sleepy or falls asleep during the interview. Another nurse-driven screen is the 4A's test. Now, please note that this one is called an assessment test for delirium and cognitive impairment. So it's a little bit different, but it is a screen. And the authors of this test chose to do this because the word screening has different meaning in different contexts. And so they describe the 4AT as an assessment test. The 4AT looks at alertness, orientation, attention, and acute change or fluctuating course for delirium case identification. It takes a little bit less than 4 minutes to administer and can also be administered by any healthcare provider. Another commonly used nurse-driven screening scale is the Delirium Observations Screening Scale. Initially, this was developed to have 25 items, but was later revised to be 13 items. It allows for nurses to document or identify delirium earlier in their observations while caring for a patient. So these are not necessarily questions that the nurse might ask of the patient in some of the other ultra brief screens, but these are observations that they can use. It has been used in older adults. It's been used in post-cardiac surgery individuals, and also general hospitalized older adults. Another commonly used tool is the NuDesk, or Nurses Delirium Screening Checklist. It's a 5-item assessment that focuses on disorientation, inappropriate behavior, inappropriate communication, hallucinations, and psychomotor disturbances for delirium case identification. It takes about 3 minutes to administer, and it must be administered by a trained provider. It initially was developed for use in oncology patients. However, it's been used in other settings as well, including general hospitalized older adults, post-operative patients, as well as those who have had cardiac surgery. And last, the Nese Confusion Scale. It was initially developed to identify delirium in those hospitalized older adults for an acute medical illness, but it's also been validated in those with advanced cancer or individuals undergoing orthopedic surgery or other surgical procedures. It covers 3 different domains and has a 9-item assessment of cognitive function, behavioral manifestations, and physiological state for delirium case identification. It takes a little bit longer to administer, so about 8 minutes, and also should be administered by a trained provider. So these are just a few of the tools that can be nurse-driven and implemented in an acute care setting. So whether that's in the electronic health record or another form, they can be easily used. So how can nurses help with delirium management? In general, there are some basic principles. We can have clear, calm communication, anticipate needs, minimize agitation, and avoid restraints. How can we anticipate needs and prevent complications? These are some simple, basic nursing-driven protocols or interventions that can also be delirium management strategies. Things such as scheduled toileting, promoting mobility and ambulation as the patient is able, promoting positive sleep routine and habits. So whether that's making sure that the unit is quiet at night, or making sure that those blinds are down at night and then opened first thing in the morning, providing adequate sensory stimulation. So if an individual needs hearing aids or glasses, make sure that they're there and that they're able to access them or help them to put them on. Involve older adults to their fullest abilities within the activities of daily living, even if hospitalized. And of course, educate and involve their family and friends. So that's a little bit about what the evidence tells us is good for delirium screening and management from a nursing-driven perspective. But Leandra, I was wondering if you could tell us a bit more about your perspective and sort of what you have done at the Milton S. Hershey Medical Center and some barriers or challenges that you may have encountered, as well as what has really helped your team.
Yes. So I think, in Andrea's past couple slides, she really just kind of summarized all the things that we do to help prevent delirium or in acute care setting. So today I'm just going to share with you what we have done on 6 Acute Care Medicine that focuses on 3 strategies. Now, I will tell you, currently, we have no screening or assessment tool in order to positively identify patients with delirium, at least in a floor setting or an acute care setting, and also in our intermediate care setting. Now, we do have a screening tool that is utilized in our ICU settings and also in our emergency room department. But currently, we are actively looking at trying to implement a screening tool for those patients that we can identify them as having delirium. But for anybody that's worked in the clinical care setting, we all kind of know what delirium looks like, especially that hyperactive delirium that Andrea had described at the beginning of the presentation. So as a unit, we knew and we know that delirium exists and that our older adult patients are high risk for it. So what we did is we actually looked at 3 strategies. And in the next couple of slides, I'm going to tell you a little bit about each of these strategies, and then also describe some barriers that we had with each of them. So the first one is the Hospital Elder Life Program. The second one is mobility, which Andrea said before, impaired mobility is a risk factor for our older adult patients for delirium. And then lastly, just looking at our geriatric staff competency, how much education is our nurses and nursing assistants and other disciplines receiving, how to best care for those patients that are actively experiencing delirium or at risk for delirium. So first of all, I just wanted to give you an overview of our unit to kind of set the stage for you. So 6 Acute Care Medicine is a 44 inpatient bed unit with 4 observation beds. That observation beds, those are our only shared spaces. All of the rest of the beds are private. So we have a total of 48 beds. We are a medical surgical unit, and we serve patients with complex medical needs. We also serve patients that might be on telemetry, and we also do take care of some patients, which we call complex care, down our one hallway that can maybe just require a little bit more frequent monitoring and maybe have some special needs. And our main service line is internal medicine. So the first strategy I wanted to describe to you today that we implemented is called the Hospital Elder Life Program. This program has been around for a very long time. When I first started doing research on this is actually brought back to us from another conference. And we, as a unit and as a nursing leadership team, wanted to try to implement this because we knew that it would just provide not our older adult patients with just an opportunity to help prevent their functional and maybe even their cognitive decline. So really, it's an evidence-based program that provides and promotes optimal care for our older adult patients during hospitalization. It focuses on preventing that functional decline and also that cognitive decline that we talk about that puts our older adult patients at risk for delirium, but it also helps to prevent falls and helps our older adult patients return home at their maximum level of independence, which is a goal for a lot of our older adult patients. So it takes certain intervention protocols that are targeted towards 6 major risk factors for cognitive and functional decline, which includes patients that have cognitive impairment, that are experiencing sleep deprivation, immobility, vision and hearing impairment, and then also dehydration. So it takes simple intervention protocols, which I have listed here, orientation, or like what we like to call on our unit reorientation sometimes as well, therapeutic activities, just really focusing on some cognitive activities for our patients, whether that would mean providing them with a book or a magazine, some crossword puzzles or word searches in order to kind of keep them more active and not just staring at the ceiling as they're lying in a hospital bed. We also tried to focus on our sleep enhancement and then mobility. So we focused our Hospital Elder Life program on all patients aged 65 years and older. With our process, we really looked not only for the suggestions from the Hospital Elder Life program to adopt this onto our unit, but they had very specific inclusion and exclusion criteria, which we then took and kind of modified to meet our patient population. Some of those exclusion criteria, one of the most important things is we wanted to make sure that our patients would benefit, those that we identified with for this program would benefit the most from these activities. So we wanted to make sure that they were going to be able to communicate with us, either verbally or at least in writing. So any patient that really had a diagnosis of aphasia, whether it's receptive or expressive aphasia, we did not consider them a candidate for this program. Those with a terminal condition, those that might have had or currently experiencing some combative or dangerous behavior, we excluded them as well. Also those that might have a diagnosis of severe psychotic disorder or severe dementia, because again, we want to make sure that we are able to communicate and they're able to communicate with us as well. And then further down the line, we did look at some different precautions that maybe patients were on, such as neutropenic precautions or airborne precautions, especially related to some of the infection prevention guidelines that are already set for our organization. So how did we implement this? Well, I will tell you at first, we had a grand plan of and a process that we had put into place. And then within the first year, we actually had to modify that plan. So originally our process was that our staff nurses, taking the information that they received through an education, would be able to positively identify patients that would fit the criteria for the Hospital Elder Life program. They would then notify our charge nurse, which would then put that on our assignment board, signifying to our nursing assistants that these patients would need those intervention protocols. So our intention was to have our nursing assistants be the key player in this Hospital Elder Life program. They would specifically be assigned daily to this role. So what we found is that this kind of caused a little bit of inconsistency, especially with staffing needs of our unit and of our organization. So then we had to end up modifying our approach. So within the first year, we actually decided to do a team approach, which is what we currently do now in our current state. So it really takes each member of our healthcare team and gives them a role in the Hospital Elder Life program and in those intervention protocols. It really makes those key items that Andrea described before as part of the everyday care and part of our unit culture. So what we do now is we have our charge nurse and our bedside nurse working together in order to identify patients that meet our inclusion criteria. Our nursing assistants still play a key role in the intervention protocols. Specifically during the day, we want to get them up and moving, which relates to our next strategy that I'm going to talk about. We also want to make sure that they're also providing some of that reorientation, looking to make sure that our patients have their sensory aids, which is sometimes a huge barrier for older adult patients and also puts them at high risk for delirium, especially when they can't hear or see you. And then also too, we got our patient care secretaries involved in this program. They really help to try to provide some therapeutic activities and maybe even some companionship throughout the day. We partnered with our humanities department with a program that they had started called All About Me. So our patient care secretaries would go around to these patients, and if the patient would like to participate, they ask them, would you tell us just 3 non-medical things about you? So we could really try to help identify maybe what was important to these patients and really get to know them through what they're sharing. This was really something that some of our patients really enjoyed. And it also really helped them to try to even just reminisce about what was going on in their life and being able to share that with us. We also had other programs, which I'll talk about, that kind of came about during COVID-19, because at that point, visitation was limited. So how can we best, provide these patients with visitors? Before we had to implement those policies, we actually started having volunteers. We partnered with our volunteer department and had volunteers coming in about 3 times a week just to provide some companionship and just sit down and talk with these patients, really keep their cognitive ability to try to help prevent that further decline. So what were some of the barriers that we saw with the Hospital Elder Life program? So like I said before, staffing. Again, that really provided some inconsistency with our role that we had hoped to establish for our nursing assistants, not only on our unit level, but also in the organizational level. So that's why we ended up going to more of a team approach. These next two kind of play hand in hand. So just buy-in of our key staff members. Again, our key staff members were our nursing assistants. So myself, before we implemented this program, myself and our nurse educator, we actually ended up having an 8-hour educational day with all of our nursing assistants to not only provide them with education on the Hospital Elder Life program, but to also have them be instrumental in the process and really look at the barriers and maybe what supplies we might need in order to make this program successful. So what we found kind of along the way when we had a nursing assistant in this role is they really felt that maybe they had a lack of training in it. Even though we see that some of the interventions are very basic, it was a change in role for them. So really just trying to have them understand the importance of it and the priority that it meant for these older adult patients. And the environment of care is something that we continue to struggle with. This is something that even, NEACH and IHI really recognizes that the environment care can be a huge barrier for our older adult patients, especially with their outcomes. So one of my last slides, I'll kind of talk to you about how we continue to tackle that. And again, as I said, COVID really kind of took a hit on some of our interventions related to the Hospital Life program, stopping, unfortunately, our volunteers coming in to really help us with some of the interventions that we had into place. So the second one, strategy really relates to mobility, which again, Andrea said, one of the risk factors for delirium for hospital older adults is impaired mobility. So within our first year of our action plan for NEACH, we decided that we wanted to design and implement a proactive mobility project for patients aged 65 years and older. And what we found too is that this not only resonated with our older adult patients, but also with all of our patients. So all of our patients are able to benefit from this. So for this intervention, what we did is we actually established and created a mobility team on 6 acute care medicine. It was facilitated by our clinical practice nurse leader, and we asked for champions for mobility. So it was registered nurses and certified nursing assistants from both shifts, day shift and night shift, that really wanted to make an impact and really make this a priority and also change our culture on our unit to get back to moving our patients. One of the most important things that we saw when we first created our mobility team is we asked, why aren't our patients moving? And again, mobility is something that not necessarily means ambulation, because we know that some of our older adult patients are bedbound or wheelchair bound. So why aren't we not only getting them up, maybe up into the chair or ambulating in the hallways, but why aren't we doing just simple passive range of motion activities with our patients? And one of the things that we just kept hearing over and over again was that in particular, our nurses and nursing assistants didn't feel comfortable with assessing or even screening what baseline mobility is for our patients. We had no way to do that. And some of them even said they like to wait for physical therapy or occupational therapy to come around and really partner or champion and tell them how this patient can move and how they can move safely. So what this team actually did is they looked through different screening tools, and they found this iMove assessment tool, which on the next slide I'll show you then, but it stands for Independent Mobility Validation Examination. So this tool that was found by our nurses and really championed by this mobility team was implemented on our unit. And what we found is that it actually gave our nurses the confidence in order to assess and screen our patients for their baseline mobility. So Andrea, if you just want to go to the next slide again then. So this is the screening tool that we utilize today. It is still on paper format in our organization, which we are actively looking to get it part of our EMR. But it is really something very simple, and our nurses are able to screen our patients when they first roll up to our unit. So if the patient comes up and, on their stretcher from the emergency room, and they get up and walk from the stretcher into their bed, we automatically know that they're at a 12. So we know that they can walk in the hallway. What makes this really easy is that the screening tool really stops when we have to provide assistance to the patient. So more importantly, so that patient comes up from the emergency room, they sit at the side of the bed, but they need assistance to stand. That is where we would stop, and they would score a level of 5. So what this translated then into is that our mobility team took this tool and partnered with our physical therapists, because we all know that we can see if a patient can ambulate in the hallway. We know what we should do with them, that we should get them up and moving and have them ambulate in the hallway. But for those patients that maybe scored a little bit on the lower side, like a 1 or a 2 or a 3 or a 4, what certain activities can we do with those patients to help promote mobility for them and also help promote that functional decline? So our physical therapist actually gave us a list of activities that are actually hanging in each of our patient rooms that our nurses and nursing assistants can do with those patients. So what's really great about this is that it partners all levels of discipline. So our physical therapists can see kind of what we're doing with our patients. And it also allows, the family members and the support persons to really see that we're getting them up and moving the best that we can. So I wanted just to tell you some of the outcomes that we had with this mobility proactive ambulation program or mobility. So in our first year, we actually started collecting some data. Our baseline data that we looked at multiple things, but I'm just going to tell you about our ambulation rate. So the ambulation rate for our patients in our baseline year was probably around 45 to 50%. And this is only for patients 65 and older. So after we implemented the iMove tool, our unit actually reached, and in the past 2 years, we've sustained 65 to 75% ambulation rate in patients aged 65 years and older. And in particularly, we also increased after the first year by 50%, the average number of ambulation events for our patients aged 65 years and older to 1.5 events per day. So that really kind of made me realize that this team, the mobility champions and the mobility team, really changed the culture in our unit, and our nurses and nursing assistants really made it a priority. Now, how this really helps patients with delirium is that a lot of them like to get up and move. So now our patients, instead of just trying to keep them in the bed, which then can lead to further agitation and further, consequences that, Andrea had discussed before, trying to avoid, maybe chemical restraints or physical restraints. We see it as an opportunity to be like, okay, we can get them up and moving. Let's have them walk in the hallways, and let's try to make it the safest way to get them up and moving. And then I just wanted to share too another positive outcome for older adult patients, not really related to delirium, but we also saw a significant decrease in our hospital-acquired pressure injuries for 65 years and older. After the implementation of the iMove, the 4 months afterwards, we actually had 0 acquired pressure injuries in our fiscal year, and we had a total of 8 months within our first year that those patients were actually pressure injury free, which is a really great achievement, especially for a medical surgical unit and, the high risk patients that we receive. So what were some of the barriers for the iMove and the mobility? Now, we all know, again, that mobility is not only a key intervention for older adult patients, but for all of our patients. But again, just looking at how it really helps manage delirium, again, because, getting them up moving, getting them to move during the day really kind of helps them to also sleep at night as well. So one of the barriers that we had, again, was just the buy-in of our key staff members. So we had mobility champions identified on our unit, but they were the ones that really provided that peer-to-peer education and really held their peers accountable to make sure that they were assessing and accurately assessing their patients, and making sure that they were getting them up and making this a priority. One of the barriers that we're seeing now is just resources related to the implementation across our organization. We are really hoping to get this sort of assessment tool because we saw such positive outcomes on our unit across our organization. Again, I listed the environment of care because one of the key things, maybe for safety for older adult patients is just having handrails in the hallways, especially during ambulation activities. And then again, some of the units that we were hoping to spread this type of initiative, was really affected by COVID-19. Even though those patients, we tried to encourage, to really get up and moving the best they can based on our infection prevention guidelines, because those older adult patients in our first wave that we saw were 65 and older. And a lot of them did experience some delirium or had dementia. So making sure that we can still get them up and moving the best that we can, but making sure that we're doing that safely, not only for them, but for our staff. So lastly, the last thing I wanted to talk to you about is just increasing our geriatric staff competency. Just kind of realizing that a lot of our nurses and nursing assistants, yes, they knew what delirium was. Most of us can identify maybe what hyperactive delirium looks like because it's the patient, that is now agitated or screaming and not letting us do or provide any care to them. But what about those other types of delirium and the management of them? The hypoactive delirium, is the most prevalent. So really just helping to increase the recognition of that through education. So what we did is we actually got approval for a gerontology certification, which was really big. So some of our nurses on our unit also have gerontology certification, so they're dual certified. We also look to try to establish what we call a geriatric resource nurse role on 6 acute care medicine. This really aligns with the work that Nese really provides in the education that they provide. One of their models is to really kind of focus on GRNs and having the nurses have education. Lastly, to the geriatric patient care associates. So all of our nursing assistants go through education when on hire to our unit related to geriatric patient care associate. And then, just looking at the age sensitive care for all of our disciplines. What type of requirements do they have for education for older adult patients, and particularly related to delirium? So 2 more things I wanted to say, again, the environment of care is something that is really big as far as a barrier. According to Nese, the environment of care should reflect our age-sensitive principles. So how did we conquer that? Because we know that, it put our patients at risk for delirium. So for our reorientation or orientation, we actually provided digital clocks that were large enough that our patients could read the time and also the day or the month. We provided hearing amplifiers for those that might not have had their hearing aids, or we were unable to get batteries for them. We also partnered with our patient experience to make sure that we had magnifiers and readers on our unit for those patients. And then lastly, I just kind of wanted to share with you some of our next steps. So as I said before, I'm now leading a steering committee that really works with IHI and NEACH. And one of the work groups is really focused on mentation, that 1M. And currently they are looking at identifying a screening or assessment tool for delirium, not only in the ICU settings, but also on the floor and intermediate care settings. We're looking to initiate the proactive ambulation throughout our organization. And also to just focusing on our geriatric staff competency, not only on our unit, but kind of throughout the organization as well.
And so I think that's it from us. So if you have any questions or comments, we look forward to them. Otherwise, thank you for your time and attention.
Yeah. Well, Andrea and Leandra, thank you so much for an amazing presentation. It was great to hear the key concepts and some data related to adverse outcomes for older adults. Always a good information, so valuable for nurses and other healthcare providers. Andrea, thank you for reviewing various screening tools, some that can be implemented a little more quickly and others that maybe have a little bit more detail. And it's great to hear, Leandra, that you're reviewing those and maybe considering consistent implementation of those to help with early identification of delirium. But it was also fabulous to hear about the hospital elder life program that's being implemented, and all of the strategies, as well as some of the challenges and facilitators you've needed to implement to get that program moving forward. It was also interesting to see how that aligns with the age-friendly care movement, which, you know, we're a big proponent of as well at our college. And some of the specific strategies you're using to reduce the risk of delirium with older adults that are hospitalized. So thank you for that very interesting and informative presentation. And certainly we can open it up to anyone that may want to unmute and either share a comment or ask a question or put a question into the Q&A feature or the chat. We're keeping an eye on both. Do you see anything right now?
I was going to ask Andrea about the screening tools that you were referring to. Are most of those free and kind of available online as a reference, or do you have to have access to them?
No, most are available to use. If you do want to use them, I would probably write a request to the authors of those screening tools, but for the most part, they are open and people want you to use them. I think that's the key, right? So whether it's a larger healthcare organization or a smaller group, we want to see those distributed so that we can start to improve outcomes for older adults.
One of the things that I saw as a positive also of the hospital elder life program and the nursing assistant involvement with that is that very often they know a lot about the person, the older adult themselves, especially those maybe living with dementia. And that assessment in terms of understanding a little bit more about what matters to them and their daily routines and practices can be very helpful. If you could both of you talk about a little bit about why it's important to really understand that baseline of a person in relation to identifying delirium.
Maybe I can kind of speak to this. You know, that was really kind of the goal. You know, what you said, you know, our nursing assistants and also our nurses too, just understanding and really trying to keep our older adult patients on their normal daily routine. You know, we hear so many times, you know, patients wanting to get up at 4 a.m., but we're like, no, you know, go back to sleep. It's still only 4 a.m. But really, and then, you know, that's their time that they want to get up and they want to get themselves ready. So really kind of changing their routine can really have some effect on their, you know, cognitive impairment. So really kind of understanding their baseline And for those patients that have dementia, really connecting with their family members in order to maybe understand their routine, because that in itself, especially in an acute care setting, will help us provide better care to those patients. So maybe we're giving them, their medications crushed in applesauce, but they've hated applesauce for the past, 20 years of their life, and they prefer something else. Or, just looking at their different food preferences, or maybe just their bedtime routine is really important, because when you have our older adult patients and they're hospitalized and we take them out of their routine, especially those with dementia, that is when you can see some aggressive behaviors and really just kind of the escalation and agitation. And then a sense, can also prevent, staff harm, patient harm, and really hinder, their outcomes.
And Andrea mentioned this in her presentation, but so maybe she can comment first, and then Leandra, you can ask. But we do have a question from Marie about, the importance of encouraging family involvement when an older adult is hospitalized, and do you include them in their care at the hospital?
I mean, I think best practice would tell us that we include them in their care to the fullest extent possible. And especially with regards to what Leandra was just talking about, or understanding their baseline. I mean, they're critical to understanding some of that baseline knowledge, and their likes, their dislikes, their preferences, what might make them more or less agitated. There are some family members who are unable to be at the bedside. And especially in the time of COVID, we've experienced that more and more. And I think it's brought more challenges. And I don't know if Leandra's had specific challenges or not.
Yeah. So, just to answer the question, do we allow, family members to stay at Hershey? Currently, before COVID-19, we did allow, and we did encourage our patients and family members or support people to stay, especially with those patients that have dementia. And they're maybe the ones that provide care for them, to be at the bedside, because it did help us to, better provide care to our patients. Now, COVID has definitely put a little bit of a wrench in that, but we are always looking for exceptions. And what we always say, what is in the best interest of the patient, especially with our older adults. So that is just a real focus, especially for those that have dementia, or even those that are now experiencing delirium on our unit. We always ask, what is the best interest for the patient? And should we, allow maybe a visitor exception, and to allow caregivers 24/7. So I think that's really a testament to kind of how we show a priority for our adult patients.
Well, and that's a great kind of closing statement, prioritizing care for older adults and individualizing that, including families. So thank you for sharing that. Unfortunately, we're a little bit out of time. There's all kinds of positive comments in the chat, Andrea and Leandra, regarding this seminar. So thank you so much. We also put the link to the evaluation tool in the chat. It is required for registered nurses seeking contact hours, but we do ask that all participants complete the evaluation within 1 week to provide us data and feedback on this event. You will also receive it via email after because you registered. So you will receive it within a day. And again, thank you to everyone for joining us today for this fabulous presentation. Again, to our speakers, Andrea and Leandra, for your time and effort and sharing your expertise with us today. And we hope everyone has a great rest of your day.
Thank you, guys.
Thank you.
Thank you.